This topic is complications during the third and fourth stages of labor. Let's first review what these stages are. Stage 3 is the time from the birth of the baby to expulsion of the placenta, or the delivery of the placenta, as seen in the image. Stage 4 can be thought of as a recovery stage. It's 1 to 4 hours after birth. It includes maternal physiological readjustment. One complication can be perineal lacerations. These are spontaneous tears in perineal tissue that occur during childbirth. It is normally from the stretching the perineum needs to do during the expulsion of the fetal head. They are classified by depth of the laceration and structures involved. They are categorized from first degree, with just the perineal skin and vaginal mucous membrane involvement, all the way to a fourth degree laceration, which involves the anal sphincter and goes all the way through to the rectal mucosa into the rectal lumen. The lacerations can be repaired with sutures, but some first-degree tears are typically left unrepaired. Some clients are more at risk for these lacerations. Risk factors include primiparity, first-time birth, prolonged second stage of labor, fetal macrosomia, where the fetus is large, operative vaginal birth with forceps or vacuum-assisted birth. Complications. These are normally associated with third and fourth degree lacerations. Dyspareunia, pain during sexual intercourse, and perineal pain. Wound infection or dehiscence. And anal incontinence, especially if the client had a third or fourth degree tear that involved the anal sphincter. And rectovaginal fistula, a connection or pathway between the rectum and vagina. Nursing interventions. You can see here some different techniques for pain management. Medications, pain-relieving spray, cool packs. This will help with pain and decreasing edema. Witch hazel pads, sitz baths, and position the client laterally. This may help decrease pulling and pressure on the area of injury. We want to prevent constipation to avoid pressure in the area that is healing, so encourage fluids and increasing fiber intake, and stool softeners may be necessary. Inform the client that nothing should be inserted vaginally or rectally until approved by the healthcare provider. And teach the client to report signs of infection, like fever, purulent drainage, and pain that is not improving or becomes severe. Another complication is retained placenta, which is defined as no placental expulsion within 30 minutes of fetal delivery. This may indicate placenta accreta spectrum, or PAS. Remember, that is when the placenta is abnormally attached to the wall of the uterus. We'll talk more about this in a moment. Risk factors for a retained placenta include previous retained placenta, uterine abnormalities, which could be a bicornuate uterus, the uterus is heart-shaped, or uterine fibroids. These are growths in the uterus that are not cancerous. Extreme preterm birth, because the placenta is meant to stay attached for 40 weeks. Intraamniotic infection, because the inflammation and the possibility of damage it may cause to the lining of the uterus. And intrauterine fetal demise. This may be due to whatever caused the demise, which may also affect the normal functioning of the placenta. Complications of retained placenta. Postpartum hemorrhage, because the retained placenta causes the uterus to not be able to contract down properly. That contracting helps with vasoconstriction, so without it, it places the client at risk for bleeding. Endometritis, inflammation and infection of the endometrium part of the uterine lining. Management involves removing the retained parts of the placenta with manual removal. And if it is not successful, the client may have to go to surgery and have a dilation and curettage. Placenta accreta spectrum, PAS, is the abnormal attachment of the placenta to the myometrium, which is the middle layer of the uterus, instead of the endometrium lining of the uterus. So the placenta attaches too deeply into the uterine wall. This is also known as morbidly adherent placenta. This is categorized by depth of invasion of the tissues. Risk factors include previous PAS, prior uterine surgery causing scar tissue, like dilation and curettage, cesarean birth, or other surgeries involving the uterus, like fibroid removal. How does this client present? The client may be asymptomatic, and this may be diagnosed as an incidental finding on the routine second trimester ultrasound. Some clients may have antepartum bleeding, with or without fetal distress. And some clients will show manifestations following a birth with retained placenta and concurrent postpartum hemorrhage, with abnormal separation of the placenta from the uterine wall. You can see in this first image where there was a previous uterine scar and the placenta has attached itself abnormally to that scar and becomes too invasive. Complications of PAS include life-threatening hemorrhage. Again, when the uterus is unable to contract down properly because of the retained placenta or from damage from the placenta, the risk of hemorrhage occurs. This may require blood transfusions. You can see on the right side of the image, the invasive adhesion of the placenta has penetrated through to the bladder. So this can cause bladder or other organ damage, which will require surgical repair. Management. Many of these clients will have a scheduled cesarean birth if this is detected during pregnancy. Planned hysterectomy is also common because separation of the placenta from the uterus may be too difficult or dangerous and may cause hemorrhaging. Or the client may have dilation and curettage, where the doctor uses a curette to scrape off any retained parts of the placenta. Nursing interventions for retained placenta and PAS. Provide pain management if no epidural is in place. This could include nitrous oxide or IV sedation. This is especially important if the client requires some sort of invasive procedure. Anticipate and monitor for postpartum hemorrhage, or PPH. This may require multiple transfusions with blood products. Monitor for DIC, disseminated intravascular coagulation, which may happen if damage to the uterus causes an excessive amount of thromboplastin to be released in the maternal bloodstream. This will initially cause multiple tiny blood clots to form and then result in hemorrhage. This client may need to be transferred to the ICU for monitoring and the additional need for blood transfusions. And monitor for signs of infection. Prophylactic antibiotics may be prescribed. This often depends upon how invasive the placenta was and how complicated the removal was. Postoperative pain management, as with any postoperative client. And debrief the event with the client. This may be traumatic, especially if the client was hemorrhaging. Allow the client to ask questions and provide support. Always explain calmly to the client what is going on and what the plan is. If a hysterectomy is necessary, provide emotional support and maybe chaplain services. Again, this may be traumatic, especially if the hysterectomy was unplanned or if the client was hoping for additional children in the future.